Okay. We are online.
We are live?
Yes, now we begin.
Okay. How many total participants we have now? About 21. They're adding up. Okay.
Recording in progress.
Well, good afternoon, good evening, good morning, depending on which time zone you are in. My name is Jamal Hoballah. I'm the president of the Pan-Arab Vascular Surgical Society. And I'm delighted to be with you here today to start our first educational activity of the year. As you know, the PAVSS, Pan-Arab Vascular Surgical Society, is a new society, and we're trying our best to have numerous valuable educational programs in addition to our annual meeting. I'm pleased to say that last year, our year was a fairly productive year. We had more than 2 webinars and 2 journal clubs. And we also have an annual meeting that was very successful in Riyadh in December, along with another meeting in conjunction with the EG Vascular in Alexandria in November. This year, we're planning to do the same. Things are already well set. The first event is today, and it's going to be a journal club. We will have a journal club every other month and alternating with webinars every other month. So in January, we have a journal club. In February, we're going to have a webinar, and then March, another journal club. The webinar for February is already assigned to Dr. Carlos Pshara, who's going to talk about PMAGs, physician-modified endographs. And we are planning our annual meeting this year to be in Amman, Jordan in December. So please mark your date. I will remind you about that later. But for now, and to be on time, let me see how many participants we have. We already have 41 participants. We are really delighted this time to have selected 2 very interesting papers. And we have 2 exciting speakers who are going to present them. The most interesting part about this is it is not very common to find that the panelist is the senior author on the paper. And we are delighted to have a senior author of the first paper with us, as well as the senior author of the second paper with us. Professor Mahmoud Malas, needs no introduction. He's the chief of vascular surgery at the University of California in San Diego. He has been one of our people that we are so proud of his contributions to vascular surgery. And he will be discussing the first paper after it gets presented by Dr. Sami Nabhani. So I just want to say that I am also welcoming you again on behalf of PAVSS and the Pan-Arab Vascular Surgery Society board members. And I'm delighted to be co-moderating this journal club with my very dear friend and board member, Professor Muhammad Omar Al-Farouk. So I will start by presenting the first speaker. Dr. Sami Nabhani is a vascular fellow at the American University of Beirut, and he is going to present the first paper, EVAR versus open long-term outcomes. So Dr. Sami, please go ahead. The floor is yours.
Thank you, Dr. Hoballah. So I'll be sharing now my PowerPoint. Okay. Is it visible to everyone?
Yes, if you can move it to the slideshow.
Okay.
Full slide, yes, perfect.
Okay. So thank you, Dr. Hoballah. Thank you, everyone. Thank you, Dr. Hoballah and Dr. Malas, for the opportunity to present today in this prestigious society. It's really an honor for me. And without further ado, I'll be presenting this very interesting topic article, which is titled Long-Term Outcomes Associated with Open versus Endovascular Abdominal Aortic Aneurysm Repair in a Medicare Matched Database. And It was published by Dr. Mahmoud Malas, who we are privileged to have with us today, back in 2022 in JAMA Network Open. And there was no conflict of interest disclosed according to the authors. So the aim of this article is to really, as the title of the article suggests, it is to compare the long-term outcomes of endovascular versus open repair of abdominal aortic aneurysm. And just to give some background information before jumping into the study itself. So the use of EVAR has significantly risen since 1991, currently representing almost 75% of AAA repairs. And research, including major randomized clinical trials like DREAM, EVAR-1, and OVER, indicate that EVAR actually leads to reduced perioperative mortality and morbidity compared to the open repair. However, when it comes to long-term outcomes, we have seen more controversy with no significant differences in the long-term mortality in studies like OVER and DREAM over 14 and 15 years respectively. And even in EVAR-1, it was noted that the aneurysm-related mortality was actually higher in the EVAR patients, and that was especially notable after 4 years from surgery. However, just like in the OVER and the DREAM trials, the overall mortality showed no significant differences after 15 years. Also, multiple observation studies actually reaffirmed the concerns of late mortality after EVAR. So as for the study itself, so it is a multi-center retrospective cohort study which analyzed collected data from the Medicare Matched VQI Vision database. So keep in mind that this is a Medicare matched database. So basically, we are only taking patients that are 65 years and older. So keep this in mind. Which includes comprehensive demographic, procedural, and post-operative information from over 800 hospitals from across the US and Canada. And it basically included patients that underwent first-time intact AAA repairs between 2003 and 2018, and hence them into two groups of EVAR and open repair. Patients who had ruptured aneurysms, who had concomitant procedures, or individuals who had prior AAA repairs were actually excluded from the study. The baseline characteristics included many things, including a year of repair, age, sex, race, ethnicity, BMI, smoking status, and comorbidities, along with the previous medical interventions, and it also accounted for a maximum aortic diameter and symptomatic presentation. As for the outcomes, it looked for the primary outcomes and the secondary outcomes. The primary outcomes of interest included the 6-year all-cause mortality, rates of rupture, and reintervention, whereas the secondary outcomes really examined within a 30-day time frame and included the mortality and morbidity such as leg ischemia, intestinal ischemia, MI, respiratory complications, and non-home discharges. So in total, 32,760 patients were included in this study with a median age of 75. 78.5% were men, 86.3% underwent EVAR, and only 13.7% actually underwent open repair. In the EVAR group, the median age was 75 with 79.9% as men. In the open repair group, 72 years was the median age and 69.6% were men. And given the significant differences in the baseline characteristics between the groups, actually propensity score matching was applied, and that was done to balance the groups, and this actually led to an absolute standardized difference of less than 0.1 in all covariates. And eventually, we went from almost 32,000 patients to almost 5,600 patients in total. So for the long-term outcomes, as you can see in this table, it is including the unmatched. It's including the unmatched cohort and the matched cohort. So first, we're going to start talking about the unmatched cohort with the N of 32,760 patients. So in this cohort, over a 6-year period, it was noted that open repair had significantly lower rates of mortality, rupture, and reintervention. And basically, if you can see my cursor, I'm pointing to the red lines here. So at 6 years, you can notice that for open repair, it is 34.9% versus 43.5% for EVAR. For rupture, it's also 5.6% for open versus 7.7% for EVAR. For reintervention, it's 9.8 versus 15.3% for EVAR. So all with statistically significant p-values. And when mortality was actually divided into shorter intervals, open repair also had lower rates of mortality between 1 to 2 years and 2 to 6 years with statistically significant p-value. The only thing that was here that was noted was that open repair had higher percentage of mortality during the first year when compared to the EVAR group, with 9% versus 8.2% with statistically significant p-value. When a propensity matching was done, the same thing was noted. So higher basically percentage of 6-year mortality, 6-year rupture, 6-year intervention rate for the EVAR group as compared to the open repair group, and also between 1 to 2 years and between 2 to 6 years, open repair had lower mortality rate when compared to the EVAR group. However, when they are compared during the first year, there was no statistically significant difference between the two groups as opposed to the unmatched group cohort. And this is basically looking at what we just talked about in a graph format. So the open repair had the higher survival than EVAR, had a higher freedom from rupture as compared to EVAR, and a higher freedom from reintervention as compared to EVAR. So one of the things that the authors actually did in this study is actually to do a stratified analysis based on the year of repair. So as you can see, we have EVAR that was done between 2009 and 2013, EVAR that was done between 2014 and 2018, and open repair that were done in the same periods of time. And this was really done due to the significant advancements that have been made in the EVAR technology over the years, which included graft design, deployment techniques, and imaging modalities. So it was really to check whether if these advancements would show any difference between the EVARs that were done in 2009 and 2013 and the EVARs that were done between 2014 and 2018. And actually, there was no any statistical difference between the two EVAR groups when it comes to mortality, rupture, or even reintervention. The only thing that was noted to be statistically significant was that the EVARs that were done between 2014 and 2018 had higher rates of reintervention, and it is basically the light blue color, when compared to both open repair groups, which are the yellow and the brown colors. One thing to note here is that as opposed to what we were talking about previously, there was no statistical significant difference between the all-cause mortality and rupture between EVAR and open group. And I will talk about this later on in a discussion as to what's the most probable cause for this. And in a sensitivity analysis here, basically they excluded patients who underwent EVAR because they were unfit for open repair. And it was noted that in these groups that the open repair had also lower rates of rupture reintervention and significantly lower mortality between 2 to 6 years. And as you can see, 2 to 6 years, rupture 6 years, reintervention 6 years, open repair had lower percentages than EVAR with statistically significant p-value. When it comes to the perioperative outcomes, the open repair, as we all know, actually had significantly higher 30-day mortality compared to those who underwent EVAR, whether in the unmatched group or in the cohort or in the matched cohort. They also had higher rates of perioperative complications, including leg ischemia, intestinal ischemia, respiratory complications, MI, and non-home discharges with statistically significant p-values. So as for the discussion, So at 6 years, the open repair was associated with a 17% reduction in mortality, 24% reduction in rupture risk, and 33% reduction in the need for reintervention compared to EVAR. While the 30-day mortality rates were lower for EVAR than for open repair, the long-term mortality benefits of EVAR actually diminished after the first 1 to 2 years. This basically aligns with the previous trials of DREAM and EVAR-1. However, one thing that was noted here is that the study showed higher overall mortality over the 6 years in the EVAR group, and this was not noted previously. In the EVAR-1 trial, what was noted was that there was a higher aneurysm-related mortality after 4 years. And the late rupture from endoleak was identified as the major contributor for the long-term mortality observed in EVAR. The study also showed that reintervention rates were higher in the EVAR group, which is consistent with the previous trials. However, one thing that the VQI vision database did not capture was that incisional hernia repair and other abdominal wall operations can actually underestimate reinterventions in the open repair group. No difference in mortality, rupture, or reintervention with EVAR that were done between 2014 and 2018 and those that were done between 2009 and 2013, despite the advancements in the field. We only noted the difference between EVAR and open repair when it comes to reintervention. However, there was no difference in mortality and rupture between the open repair and the EVAR group. However, this is most probably related to the loss of power, which is due to the reduced sample size due to the stratification that was done. And when it came to the sensitivity analysis, it was not where they excluded the EVAR patients who were non-eligible for open repair. We had the same results of having good long-term survival, lower risk and rupture in the open repair as compared to the EVAR groups. And these findings really highlight that while EVAR remains a valuable option for patients that are not eligible for open repair, we should really have careful consideration of the risks and benefits, which is crucial for patients who are candidates for both procedures. So some limitations that we will talk about is that the factors outside the database, such as the use of EVAR devices outside the manufactured approved IFU, may contribute to mortality following elective AAA repair. Another limitation is the lack of data on adherence to the long-term surveillance recommendations, which is particularly important after EVAR. Also, the study only assessed overall mortality and not aneurysm-related mortality, such as the one that was reported in EVAR-1. The study included only Medicare patients, so it did not include younger patients, which usually have more comparable perioperative outcomes between EVAR and open repair. The hospital-level factors, such as case volume and practice patterns, which have been shown to actually been linked to better outcomes in elective AAA repair, were not assessed in the study. And obviously, some bias some bias is obviously non-avoidable. Despite doing all of the propensity score matching, it is unavoidable. So in conclusion, the overall mortality after AAA repair was higher with EVAR than on open repair over the 6 years, despite the reduced 30-day mortality and perioperative morbidity after EVAR. After dividing the mortality analysis into final time intervals, the mortality benefit associated with EVAR was lost after 1 to 2 years. EVAR additionally demonstrated significantly higher rates of 6-year rupture and reintervention. And although EVAR remains a highly valuable treatment modality, especially in patients who are not candidates for open surgical repair, open repair should be carefully considered in patients who may be poor candidates for EVAR. Adherence to IFU and long-term follow-up recommendations two key factors that lie outside the scope of the database and warrant further investigation with respect to the long-term outcomes. So our impression really is that this is a very, very strong study, long-term study, with a good sample size, and even propensity score matching was applied. Patients who were not suitable for open repair were actually excluded, and this was tested. Also, they studied the difference between EVAs and different time frames to assess if there was any advancement, if the advancements actually led to a better outcomes in the EVA groups. And Obviously, this was done by a highly respected group of physicians, Dr. Mahmoud Malas and his team, who are well known to have advanced vascular surgery really and provided a lot for this field. Also, the study provided data that supported previous trials such as the EVOR1 and the OVER and the DREAM. And actually, it raised some things to really think about and investigate. So check the issue with IFU adherence. So it was in some papers it was noted that a lot of EVAs are being done now without really adhering to the sometimes not adhering to at least one IFU characteristic, and such as, for example, aortic neck calcification, or very tortuous iliac, or very tortuous neck, or angulated neck, and so on, to really check aneurysm-related mortality and not only the overall mortality, to have a long-term surveillance, which is very important in EVAR patients, and maybe having this surveillance would improve the EVAR morbidity and mortality, and to include younger patients and not only include the patients who are above 65. So in general, our recommendations is that the choice between open and endo repair should be guided by a comprehensive evaluation of individual patient risks, preferences, and long-term health outcomes. Clinicians are encouraged to discuss the potential for complications and the need for possible reintervention with patients when deciding on a treatment approach. Further research is needed to refine patient selection criteria for each approach and to improve the long-term outcomes. And continuous monitoring of outcomes in both groups should be maintained to adapt surgical strategies and enhance patient care. Thank you, everyone. This is an image of Byblos, Jbeil, which is a nice city in Lebanon, and we hope to see you all in the summer here. Thank you.
Thank you, Dr. Nabahani. It was a very clear presentation. I'm delighted that you shared this, presented a nice summary and nice assessment. I would like to ask the audience if they have any questions, any comments, so please write them on the chat, and I will pass them on to the panel and discuss it. So let me start with the first question to Professor Malas. Again, why is it that the intervention rate was higher in the EVA group in the 2014 to 2018? How do you, what do you really think went on here? Is it because people are becoming more pushing the envelope and not adhering with the IFU, or what do you think the cause? And please.
Yeah, thank you. First, Sammy, really great presentation. Sorry, guys, for the background noise. I'm literally in the airport here, so I'm sorry if I'm not wearing a suit, but I'm really honored to be among this amazing group of panelists. So I think Sammy did an amazing job, and reviewing the paper. To answer your question, Professor Jamal, I think you're absolutely right. I mean, we noticed a dramatic increase in the number percentage of EVAR over the study period. So if you look, when I started doing EVAR with V, maybe 5-10% of people got EVAR, and there were only a couple of centers, and they were very, very sick individuals. And now that shifted to over 80-85%. So every analysis we've done nationally, the endovascular repair now is taken over, whether we like it or not. It's up to 85%. There's no question that people are becoming more and more cavalier and pushing the envelope and treating patients that absolutely should not have been treated. There are several studies already in the literature that shows almost 40-50% of people treated with EVAR in the United States do not meet IFU, meet the anatomy criteria. So I think that's probably one of the reasons why there is a lot more reintervention. Part of it could be also the number of the sample, statistical stuff that happened, loss of follow-up, and all that. That's mentioned as well. So, initially when we did the study, we actually had follow-up up to 10 years, and there was 50% reduction in the risk of reintervention with the open, and 35% reduction in aortic related rupture, aneurysm-related rupture. with the open compared to endo. And then because the number of risk was very low at 10, because a lot of people lost to follow-up, we lowered it back to 6 years because that was like more logical to present 6 years data. But we actually have data to 10. The answer also, Sammy, there's no question about the limitation of the study. The problem with VQI it doesn't have a very good follow-up, but it has now since 2014, 18, they started adding aneurysm characteristic, like you mentioned, the neck diameter, the angulation, and all that. But in order to overcome the follow-up, we start using vision, which is a big project that happened. It was NIH funded, it was in Cornell, and we were part of that to kind of link the data between VQI to Medicare. And you guys might not be very familiar with Medicare, but nothing happened in the United States without paying, like every part of the world. And Medicare pay 80 to 90% of all the costs of health in the United States for a patient over the age of 65. You automatically qualify. So you cannot hide death. You cannot hide reintervention in Medicare because someone has to pay, which is Medicare. So this is why we linked it to Medicare, because at least we can get very accurate long-term follow-up as far as mortality and reintervention. But then we don't have the granular data, like Sammy mentioned, about is it aneurysm-related mortality. We can tell if the patient died from rupture, but we can't tell, which is very close.
So why is it that the aneurysm-related mortality was not included? Is it because the VQI data does not provide it, or
because Medicare data doesn't specifically?
Medicare data does not provide it. Okay. The next question is. What about the bias with respect to patient selection, not having the younger patients, and how does that, do you think, really affect the data?
Yeah, no, absolutely. I mean, there's no question. Anytime you're doing any retrospective analysis, there's a huge selection bias because, we don't know if that patient really, from the get-go, would have been better with EVAR. That's why they got EVAR versus, better with open. But as you can see, as the data progressed and with almost 86% of patients getting EVAR, then I know that many patients are getting EVAR probably could have been okay with open repair. Cannot be that 86% of the cohort are not eligible to open, right? So, I think there's a huge selection bias in the study, but I think in a way that probably majority of vascular surgeons many of us are offering endo to patient that can definitely withstand or handle an open repair, younger patients. And that's one of the problem with vision as well, because like Sammy mentioned, this Medicare kick in when you're 65. So that's why the cutoff age of 65. But the other thing is, we also know that probably many of the people getting EVAR probably don't have a good neck or EVAR, or might not have good access vessel, but we're really pushing the envelope and doing EVAR on these patients. Because the patients, I mean, Sammy showed it. I mean, there's almost threefold increase in mortality post-operative with open. There is 6 to 8-fold increased risk of intestinal ischemia, leg ischemia, all this complication that happen, renal failure and all that post-operatively. So there's no question that no matter how good you are with open, you're still going to have more complication post-operatively. So, this is the biggest dilemma we have today. Do we choose an operation that has higher complication rate post-op in order to reduce the long-term reintervention and have more durable operation? Or do we choose an operation that has better survival immediately and a patient can go home faster, but then knowing that the patient is going to have a lot more reintervention and they're going to have potentially higher risk of rupture and complications long-term?
Well, I have a comment on that. I mean, it's very hard to kill a patient with an EVAR, unless you busted the aorta as you're introducing the introducer, but you can do a suboptimal job and have type 1 endoleak, but the patient will not die they will not die in the first year because you had 2 cut downs or percutaneously inserted this graft, and then you'll monitor that patient, and then a year or 2 down the road, that's when the type 1 endoleak grows and you cannot fix it, or you have to re-intervene on it. So it's very, very clear that with EVAR, you're going to have lower 1-year mortality. With open, if you do a bad job, it's going to show that day, or it's going to show that week, and you're not going to get away with it. And that's why it reflects in the first year. And one interesting thing in the study is that you had about 118 patients in the open, which is over a 15-year period. If you divided 3,018 almost over 15, that's about 200 per year. And you had about 800 centers participating in the study. It almost looks like how many, and still they had pretty good results. And I was impressed that, the mortality rate in the first year, etc. So how do you think the issue of volume and open repair is working out these days? And the second question is, how did this paper change your practice in your institution?
Yeah, so thank you so much, Jamal. As usual, very smart comment and very good dissection, looking at the paper in details. But, so the numbers you're looking at are probably after propensity score matching, but this is the largest study ever done with almost 40,000 patients in totality. But when you do propensity score matching, you lose a lot of the patient because now you're trying to find patient that matches on everything, age and comorbidity and whatnot. Now, the volume is very critical. We publish a lot on volume, and others have published on volume in open AAA, in EVAR, in carotid, in leg bypass. There's no question that volume play a role, even in TCAR. And, center also, other characteristics of the center. It's not just the volume, right? It's the ICU. You're saying it's very hard to kill someone with EVAR, but people have killed people with EVAR. A lot of time it's the ICU, it's the anesthesia, you're taking patients super, super sick and you're operating on them and then, you induce them and you kill them before you even start there. So that could happen. Now, what we do in all of these analyses typically with VQI, we cluster by center. There's like a statistical method to kind of try to adjust for center volume the best we can. And then sometimes we add to the regression model also the volume per center to try to make sure that this is not the results of different centers, technique or volume or, but rather an actual result. That the other thing is, as far as the open, there's, I think that even more dramatic, right? I mean, you might need to, the experience, I think, could play a bigger role there also in outcome. The final question you ask is about how did that change my practice? I mean, since I came from Hopkins to UC San Diego, I really pushed for open repair from the get-go, and almost like nobody was getting open aorta. And then once I started doing more and more open aorta, all of a sudden everybody wants to do open aorta because you do a good case and patient do well and they go home in 4 or 5 days. It kind of, challenge the need for EVAR in a lot of these patients. And I think it's very critical. We have a major problem in the United States as far as the experience of the residents and fellow and trainee, because they're finishing up. They have done 100 EVAR on average and maybe 5 to 10 open aorta. So, I mean, God help us, me and Cassius, if in the future we need an open repair, because it's going to be very, very difficult to find someone in 20, 30 years from now who actually know how to do open repair well. So that's a big problem we have. And this is one of the reasons I push for open when the patient has good anatomy and physiological, because I think it's great also to train our trainees to be good surgeons in the future.
Yeah, these are excellent comments and replies that reflect your experience and wisdom. I can just reassure our audience that, it is not an ego issue. If you have an aortic aneurysm open and you don't have the volume, I think it's a good idea to team up with another senior surgeon and then be 2 surgeons in the room doing the case, because you benefit from the experience and the patient benefit from the skills of the surgeon, especially if they work together as a team. We at the American University of Beirut, Dr. Haddad and I, we are partners and we often join efforts in the challenging cases. And we looked at our data comparing open and EVAR and long-term as well as cost efficiency and cost effectiveness. And to us, almost seems like in our part of the world, the cost effectiveness of open in the long term tends to be a little bit more in favor of open, in addition to the lower reintervention rates down the road, especially that the reintervention rates typically in our cases were for hernias and hernia repair and were not for limb ischemia or aneurysm-related complications, were more for closure. So if one addresses these issues of closure, meticulous closure or closure with a patch or closure with a dacron, there are a lot of things that still can be done to improve even the outcomes of the open repair. I don't want to be taking away all the questions. I'd like my co-panelists, Dr. Omar Al-Farouk, Dr. Nazal, and Dr. Sha'ar to ask questions. I'm going to stop asking any question myself. So, but I was trying to answer the questions that were placed on the chat list. So, Dr. Omar.
Okay, yes. Thank you very much, Professor Malas. I really enjoy every time I listen to your paper or read it. It's very, very enjoyable. It's very hard work, and thank you very much. I have a question here from one of the attendees, really, from Dr. Luis Navarro. Professor Mahmoud, what is the incidence of EVAR failure in your hospital, Professor Malas?
Sorry, let me turn that. Yeah, so, the failure, define failure. Are we talking about not technically being able to do the EVAR? I think it's probably 0%. Because we select the patient very carefully. We make sure their anatomy is good, neck and access and whatnot. So if you define technical failure, which is inability to deliver the stent graft, deploy the stent graft, finish the case, then that's 0%. If you define it as an endoleak at the end of the case, like type 2 endoleak, probably 10 to 15% of patients at the end of the case will have type 2 endoleak, like everybody else. Yeah. Now, if we choose the neck appropriately, a good landing zone proximally and distally, the type 1 endoleak become very, very rare in type 3. So we don't leave the room unless we fix it with type 1 and 3 or any high pressure endoleak. Now, if you also add like the safety and you look at mortality, if you want to add that to the technical success and whatnot, I would say the mortality rate from EVAR in our institution is less than 0.3%.
Yeah.
Very, very low.
Yeah. And I would like to thank you very much because we had in UK a similar study by Roger Greenhalgh, which he followed EVAR versus open for a period of 15 years. And the same conclusion that you had, you get an advantage in better, less mortality and less morbidity with EVAR, but you pay this price and they become equal in UK at 10 years, but in your study at 6 years. So the price that you have gained with better mortality, already you have lost it in 6 years. And I got the same conclusion as you. Before, I did not consider open for young fit patient at all. I was just totally EVAR to all of them. And after this study, it actually changed my practice. And there is definitely the rule of having a good open repair to young patient fit for open and definitely fit for EVAR. This is the same conclusion that Samer Qusayr, who I was hoping that he will be with us in the Journal Club, had the same conclusion. So I totally agree. And back to Professor Munir Nazal, if you want to ask any question.
Dr. Munir, any comments?
Maybe he's been called for an emergency theater. I know him because he left the laptop in his office. And thank you very much, Professor Malas. I know your airplane is waiting for you. And this was a precious 15 minutes for us. Really very precious. Back to you, Professor Jamal Hoballah. And this idea was...
Let me ask Dr. Sha'ar, and I want to hear from Dr. Sha'ar.
Yes.
Any comments, Dr. Sha'ar?
Yes, thank you. I really enjoy this paper. Mahmoud, always great work. I look up to you when I think about outcomes research. I think you've led the field, and it's always great to be on the panel with you. I was going to make a comment actually, and it ties into the next question that was about the evolving technology and the role of the evolving technology in EVAR. And I do think that's probably playing a role, and it's going to even play a role more in the future as we that there is more and more dedicated technology to treat, complex juxtarenal or paravisceral aneurysms. In the past, you put in EVAR, if it fails, okay, it gets an explant, or you think you can do some bailout techniques. But now there's more and more, especially at larger tertiary centers, you can do a physician-modified graft, or there are other fenestrated graft and technologies where you can salvage those EVAR failures. I still think these technologies come a lot of cost. So as a society, probably we should be selective in using them and not offer them to everybody who hits the door with an EVAR failure. I truly think that patients who are younger are probably much better served with an open repair. The challenge that I find is it is hard, it's becoming harder and harder to convince the patients. At the end of the day, what I tell all my patients, we're here to help you make decisions about your health. We're not here to make decisions on your behalf. So when I see and counsel a patients for AAA repair, I present both EVAR and endo, and I try to push them or to sway them a way or another way, depending on their anatomy and their comorbidities. And I've seen more and more over the past few years, patients coming and they're already set on EVAR. And even if they're young, sometimes even as surgeons, we think, oh, you do an open AAA and that's great. But really, some of them may have, they may have physical labor, and this is their livelihood, and their livelihood or their family. And they cannot just take 6 months and not do heavy lifting, because as surgeons, we like to do this open repair and see the aorta repaired and everything. It is probably better for them long term from a health standpoint, and this is what we tell them. But they also have other consideration that we may not be as versed and as have as much insight into. And thank you.
Excellent comments. I just want to add one thing to the before we finish on this subject to the audience and everyone. One thing that we often don't pay attention to is the commitment of the patient for long-term follow-up. Because in our part of the world, it is not uncommon that once the patient has the operation and thinks that everything went fine, they may not come back for follow-up, even if you, despite telling them that you need to come back every 6 months to a year and have your aneurysm checked to make sure there is no endoleaks or anything. And you'll be surprised that you get a phone call. I just got one today about a patient who 3 years ago has not showed up for 3 years, and he's having some abdominal pain, and he's out of the country. So it's just, these are very important issues about the follow-up, and I think it should also be taken into consideration when selecting open versus endo. So I don't have any other comments to make. I have someone make a comment. It's interesting.
Yeah, I was just trying to say, sorry, that
necessarily change the prognosis. I don't know what that.
Sorry, I was just trying to say, Jamal, that this problem of loss to follow-up is everywhere, not unique to anyone.
Yeah, absolutely. Okay, well, I think we had a very nice discussion. We are delighted that Professor Mallas was able to join us from the airport. We wish you a safe travel. Move your feet on the plane so that for DVT prophylaxis, and you have a great time.
You should see in front of me. I'm sitting on the floor. There's about 300 passengers trying to load the plane, and they all giving me dirty look because I'm speaking so loud, and they hear. I put the AirPods so they don't hear your comments, but. At any rate, I'm really honored to be with you guys. Thank you for inviting me. I'm glad I was able to join. I'm sorry I'm going to miss the other papers, and happy to help in the future. Thank you so much.
Thank you very much. You've always been most helpful with all the activities of PAVSS. Thank you very much.
Thank you.
So now we're right on time. The first 45 minutes, and now we have the last 45 minutes. I'll pass now that we have 60 participants with us, just to remind you again that we're delighted on behalf of PAVSS to welcome you to our first educational activity. The journal clubs are usually ran by Professor Samer Qusayr, but he is unavailable today, and this way we had the chance, Professor Omar Al-Farouk and myself, to chip in and hold this session. Delighted that we will be having every other month a journal club and alternating with every other month webinar. And this year, the annual meeting, mark your calendar, hopefully will be, inshallah, in Amman, Jordan in December. So now I'll give the floor to my dear colleague and friend, board member, Professor Muhammad Omar Al-Farouk, to introduce the next speaker and our very dear panelist from Yale, Professor Qasim Shahar.
Yes, thank you very much, Professor Jamal. I would like to welcome very much Iyad Shahar, or Professor Cassius, as known as in United States, from Yale University. He's a Harvard graduate. He's very well known for his exquisitely very high, eminent paper publishing. He has a long career in publishing paper, a lot of aspect in vascular surgery, in the abdomen, lower limb, carotid. We're really honored and delighted, and this is one of the paper that I remember it very well, and I stopped at and read it very much. And I would like to present my dear colleague, Dr. Muhammad Ramadan. He is a consultant vascular surgeon in a Sahel vascular unit, which belong to the organization of teaching hospital and institutes, which include about 26 teaching hospital and institute in Egypt. I'd like to welcome Dr. Muhammad Ramadan. He's going to present us this very nice paper, and he prepared his presentation. Please, you can start sharing your presentation, Dr. Muhammad.
Thank you, Dr. Omar. Thank you, Dr. Hoballah. And thank you for all the panelists. Good evening, dear professors and colleagues. I'm honored to be among the board of such an elegant meeting. Thanks, Dr. Omar, my mentor along all my career since I was his resident almost 15 years ago. I'm going to present a very well-written paper published last October in the distinguished Journal of Vascular Surgery. The title is Long-Term Outcomes of Elective Endovascular versus Open Repair of Popliteal Artery Aneurysms in the VISION database. It represents the work of a team from the Division of Vascular Surgery, Stanford University mainly, and also we are lucky today to have Dr. Cassius Iyad on board. He is one of the authors, or senior author actually. He is Associate Professor of Vascular Surgery in Yale School of Medicine. Since I recently became a member in the American Venous Forum, I know he represents the program committee in the next American Venous Forum annual meeting, Venus 2025. And also we just know he became Associate Director of the VQI, so congratulations. Now, what we know about the popliteal artery aneurysm, it's by far the most common peripheral artery aneurysm. Unfortunately, it usually presents with thrombotic event causing acute ischemia, with most of the patients, actually 1/4 of the patients lose their limbs, and the emergency repairs carries a high risk of limb loss, bleeding, graft failures, and 30 days high deaths. So we know that elective repair is always better when indicated, yet it's not well established whether to be open or endovascular. We know that endovascular procedures in general have a higher re-intervention rate, and this is the main disadvantage, while the open repair have many disadvantages, maybe the long hospital stay and all the possible surgical complications. That's why to answer the question, which is better to do elective repair by open or endovascular, an randomized control trial called the OVAR, the open versus endovascular repair of popliteal artery aneurysm trial, were about to be conducted to compare both approaches, yet they failed to complete enrollment. So the authors of this article intended to prove that endovascular popliteal artery aneurysm repair is as effective and durable as open repair through revising the vascular implant surveillance and interventional outcomes network, the VISION database. So they reviewed the database starting 2010 and ending at 2019, revising the peripheral interventions and bypasses as well. The study was approved by the Institutional Review Board of Yale University and Weill Cornell Medicine, and it was written in comply with the Declaration of Helsinki on Research Ethics. For the patient data, they excluded patients that had hybrid emergency procedures or had their first procedure before the year 2010, and they included the demographics as age, sex, race, body mass index, and ambulatory status. All comorbidities were recorded, like coronary artery disease, congestive heart failure, COPD, diabetes mellitus, renal impairment, and smoking status. Also, medications like statin, aspirin, and B2Y12 inhibitors were recorded. They defined the perioperative outcomes in the first 30 days as death, hospital stay, MI, cardiac complications, pulmonary complications, hemorrhage, thrombosis, skin infection, and renal failure. And they defined the long-term outcomes to be death, limb loss, and reinterventions. They used the statistical analysis like chi-square test and Fisher exact test for categorical variables, while Coxon ranked some tests for continuous variables. Kaplan-Meier curve used for long-term outcome analysis. Cox regression analysis was used to compare the hazard of long-term events, and whenever the p-value was less than 0.05 was considered significant. They also identified the reintervention index to be the number of interventions per person per year, and they used the SAS 9.4 software for the analysis. And the standard mean difference were calculated to evaluate the cohort balance before and after matching, and an SMD less than 10% indicates a good balance. For the results, the baseline characteristics, they included 1,159 elective popliteal artery aneurysm repairs. 65 of them were operated openly, and the runoff data only of 163 patients were recorded in the endovascular group, and there were 56% of them had open 3 runoff vessels, and 30% of them had 2 runoff vessels, and only 15% had single running vessel. And for the demographic data, as we see here in these, if you can see my arrow here, the patients of endovascular group were older, more commonly older, and were more commonly on B2Y12 inhibitors. And for the perioperative outcomes, as expected, all the patients of the endovascular group were discharged home earlier with less hospital stay, and of course, they have less bleeding events, and that was statistically significant. And for the long-term outcomes, I will tell right now, for the mortality rate, the patients of the endovascular group showed a higher mortality rate in comparison to the open group at all time points. At the first year, the endovascular group showed 8% mortality versus 3.5 in the open group. At 3 years, it was 26 versus 14. At 5 years, was 41 versus 30%, and that was statistically significant. But after match, now for the subgroup analysis for the patients of great saphenous vein open repair to be compared to the endovascular group regarding the mortality, the mortality rate, the mortality incidence of at 1 year, 3 year, and 5 year were higher in the endovascular group in comparison to the great saphenous vein repair group, and after matching, this difference was still there, and the great saphenous vein group showed a less mortality than endovascular group. And for the reintervention rate, even before matching at 1 year and 3 and 5 year, there was no statistical difference. There was no statistically different difference in reintervention rate between the endovascular group and the open group. And the reintervention index over 5 years was as low as 0.37 for the endovascular group and 0.38 for the open group. For the long-term outcomes, as I mentioned here before, so in conclusion, this study showed that endovascular popliteal artery aneurysm repair has shorter hospital stay, early home discharge. The overall 30-day mortality was less than 2%. Less than 5% of patients underwent major amputation after 5 years, and 1/3 of the patients required at least 1 reintervention in both groups. so surveillance is mandatory. And the great saphenous vein was used in 70% in open repair, and it was associated with lower long-term mortality than in the vascular repair without significant difference in limb outcomes. And now to review the previous work, Lovegrove published in 2008. He did a meta-analysis, collected 3 studies. The first was 1995, and the last was 2006. And he concluded that and the early technology limited the success with high early failure and high stent-related complications. Wang and his colleagues, 2014, showed that endovascular popliteal artery aneurysm repair was associated with more re-interventions. Curie and his colleagues, 2007, showed the primary patency, secondary patency, and survival didn't differ between the 2 groups in a single center experience of 56 popliteal artery repaired. Now for the great saphenous vein in comparison to prosthetic as a conduit, Wang and his colleagues, 2007, in a single center study showed the 5-year primary patency, secondary patency were higher with great saphenous vein as 85 and 94% than the PTFE graft 50% and 63%. And as the et al. Showed in 2023 that there is no difference in patency. However, prosthetic conduits were associated with higher death and major amputations. And before this article, there was no evidence to support this recommendation. The Society for Vascular Surgery recommends that open popliteal artery aneurysm repair with great saphenous vein in asymptomatic patients with a life expectancy of more than 5 years, while patients with a shorter life expectancy should be offered endovascular repair. And the authors mentioned that they found these limitations. The incidence of perioperative complications was too low in the subgroup analysis to yield a meaningful comparison. The perioperative complications were only collected in the peripheral vascular interventions database starting from September 2016, and there is no runoff information in the open popliteal artery aneurysm repair group. My conclusion, the title was descriptive and appropriate. Although this was a retrospective analysis with a relatively deficient and heterogeneous data, which means it was difficult to obtain a high-quality evidence, yet the authors succeeded to use a statistical tool to acquire a statistically significant evidence proving the non-inferiority of endovascular popliteal artery aneurysm repair, with emphasis that great saphenous vein open repair is still the gold standard, yet endovascular popliteal artery aneurysm is safe and durable alternative. Thank you.
Thank you very much, Dr. Mohammed Ramadan. That was a very nice summary of the paper. Thank you very much. And if anyone have a question, please put in the chat. And let me start with the first question. This is a very nice paper, my dearest Professor Isha'ar. Regarding the statistics of this paper, you have used 4 statistical elements. Did you use a statistician for that paper, or you selected which parameter of statistic to use?
Thank you for your question, Muhammad, and great talk, Dr. Ramadan, on the presentation was outstanding. So we used the statistics, we did the propensity matching, and I have an MPH, so I do sometimes my own stats, and this paper was done in collaboration with the vision team, so the team of Dr. Phil Goodney, who basically developed the vision. And we did not have access to the data, but we worked in collaboration with them. And the person who did this statistics is Jar Lin, who is the co-author, and basically does all the statistical analysis for vision and for the VQI related to the vision data. So that's it. And I think, the statistics, so there's 2 ways to account, if you want to talk statistics, there's 2 ways to account for the differences between the groups. One way is to do a traditional regression analysis where you can, account for the differences and do one model that would correct for the differences between the groups. The other way to do it is what we did, which is the propensity matching.
Yeah.
I think the propensity matching gives you a better homogeneity into the baseline characteristic that that typically a regression may not be as good in correcting, especially when you have large number of patients where you can kind of do a selection process. But there's no replacement, and and one of the limitation of this paper and Dr. Malas's paper is the randomization process, the prospective study. So when you prospectively have a trial and you randomize patient into getting one treatment or the other, you remove that selection bias that is inherent to all our analysis, unfortunately.
Okay. A question came to my mind when I really read this paper regarding the subgroup analysis of popliteal artery repair with a great saphenous vein. This group you have mentioned, they have low mortality compared to the endovascular group. I have probably half of my career I have done open popliteal aneurysm repair with a great saphenous vein, and the other half was endovascular. I remember Barry Katzin around 30 years ago said this is the future, and I was not convinced. But I can't find the explanation. If you're making an incision, you get all the inflammatory markers up. You get all the surgical complication with wound infection and bleeding and edema. How come this group have lower mortality than endovascular?
So the major difference was long term. So this is not early on. This is after a follow-up of 3 to 5 years.
Okay.
And this is also due to the selection bias. So
Okay.
when the patient that are getting the bypass with saphenous vein are probably the younger and the healthier and the more fit compared to the older patient who's getting a stent or whatever endovascular treatment is getting.
Yeah.
So this is why, and this is why I think, this is why we were also very interested in looking at reinterventions. In vascular surgery, we think about reintervention as it is a one-time process. The reality, all of us take care of patients with peripheral arterial disease. I mean, those patients just, get the first intervention, second intervention, revision with the bypass. So it's ongoing, and we try to account for that. And even when we account for that with using that reintervention index, which is the metric that we've introduced in PAD, we did not find much difference.
Okay, excellent. Well, I have a question here from Professor Rashad Bashara, who is an eminent vascular surgeon in Egypt, and he is the head of the vascular department in Al Sahel Teaching Hospital and in many different hospitals. He thanked Dr. Muhammad Ramadan for a good presentation, and he said, from your experience, Professor Shahar, what stent do you use mostly in the popliteal artery area?
So we use the Viabon, you see. It's very flexible. It's covered, so it excludes the aneurysm.
Yeah.
And, we've had good success with it. And I think probably most of this, most of the user in the US use the Viabon.
Yeah.
Yeah.
I always
do you guys have, or I don't know if there's somebody from Europe, are there any other stent grafts on the markets in Europe maybe or in the Middle East that are particularly favorable for this anatomy?
We have Atrium V12 by Boston Scientific. We have also multiple non-FDA approved for that area covered stent that we use, and now we started to use multi-layer Supera, 2 or 3 layers of Supera in treating pulmonary artery aneurysm, which is just a new technique and can be available as well.
Pulmonary or popliteal? You said pulmonary or popliteal artery?
No, popliteal artery, not pulmonary. Yeah. From your practice,
So is it?
Yes.
Is it uncovered Supera? So it's just the classic Supera?
Exactly. Yes, there was a very nice study. If you put double layer, or in few cases 3 layer of Supera, all of them are non-covered. They can work like a covered stent from the hemodynamic. It was from German study of angiology, and they presented about 80 cases treating popliteal artery aneurysm with multi-layer Supera. Quite interesting technique. Maybe it's very useful to use in the clinical practice. But I think the number one in Egypt used is still Viabon. From Professor Hoballah, from your experience, do you have a preference regarding which stent popliteal artery?
We've been using the Viaban.
Viaban, yeah. Okay. We have,
But we tend to be really, we use the Viaban mainly in the high risk patients,
yeah,
and in the other ones we tend to use the saphenous vein.
yeah, yeah.
And yeah.
I still like the operation of saphenous vein, the popliteal artery. I can't resist it, and I think it definitely have a place.
I think the question remains, what's the difference, I mean, in your decision making, if you have like just one vessel runoff versus having 3 vessel runoffs? And I don't know if Professor Sha'ar would like to comment. I mean, you have things, all things equal, and you have a patient who has only a peroneal runoff versus, and you can put a stent, has a good heart, good vein. Would you go for a endograft or would you go for a vein bypass?
I think a vein bypass is really the best, unless they have prohibitive risks for surgery.
Excellent. And we have an also question from an eminent vascular surgeon in the Gulf area, Professor Martin Marish. He works in a very big vascular center in Bahrain with a lot of vascular cases. He said, what is the practice changing conclusion according to the author? So from this paper, how did it change your practice, Professor Sha'ar?
So that's a great question. I think the take-home message for me is that the endovascular interventions are probably not as bad in terms of reinterventions as prior studies have shown. I think the techniques have evolved a little bit, and maybe our patient selection is better. And I still think that greater saphenous vein in patients who have adequate comorbidities is still the gold standard. So I think these are the messages.
Excellent.
And I see that there's a question about whatever endovascular treatment. So clearly, I think the endovascular treatment is a covered stent, but you just mentioned that bare metal stents are being used in the popliteal, and I'm sure there may be other technologies coming down the pipeline.
Yeah, you remember the technology of multi-layer stenting that was tried to be used for the thoracic aneurysm. This was developed by Cardialis company, United States, for thoracic aneurysm. It worked sometime, didn't work others, but I have seen people using multi-layer stenting, which all of them not covered in the popliteal artery. Here I have very nice question. What is your ideal anticoagulation regimen, antiplatelets? Do you use DUAC for people that you have put either endovascular grafting popliteal artery or repair with great saphenous vein bypass?
So I think for saphenous vein bypass, I just do aspirin, single antiplatelets, or Plavix if they're already on Plavix.
Yeah.
For patients who get a stent without an episode of thrombosis, I do DAPT, aspirin, Plavix typically. And for any patients who has an episode of thrombosis, or I think there has been distal embolization based on the prior angiogram or on the history, then I would add an anticoagulant to an aspirin at least for a period of 3 to 6 months after the surgery, and I would switch back to ADAPT afterwards.
Okay. Here is also very nice technical question for popliteal artery aneurysm endografting. Is there a difference between using 2 pieces of endograft or 1 piece, as you need to have good proximal zone, good landing zone, and good distal landing zone? So if you found that you have only maybe 8 centimeter Viaban, would you use 2 or would you use 1 long one?
So I prefer using a single stent that covers all the lesion personally. This is my preference, regardless of whether it lands in P1 or P2 or P3.
Yeah.
I typically go to right above, the tibials to the P3 segment, because I mean this obviously the patient has a popliteal aneurysm, and I think they're at risk of developing further, aneurysmal degeneration of the remaining pop. So I always try to go all the way to the tibials.
Excellent, excellent. And a very nice question from Professor Fadi Haddad from Lebanon. He said, very nice paper and made a great ongoing controversy prior registry, especially the Swedish Vascular, had very close recommendation but stronger in favor of open when a vein repair is done. I am surprised about the equal number of intervention in the endo. Your comment.
Yeah, so remember this database is the vision database. So this is Medicare link. So all the patients in this study are 65 or older. So this is the older patients with popliteal aneurysm.
Yeah.
And the reintervention rate is high, is actually not very high. If you look at the reintervention rate, it was lower probably in both groups.
Yes.
And my interpretation is when you use a saphenous vein, your intervention is low, and probably a lot of those elderly patients that are getting popliteal interventions have a lot of comorbidities and probably are not surviving to the time to get a reintervention. And this is why you have a much better survival in the saphenous vein group compared to the elderly who are probably, to the endovascular group, are probably older, sicker, and probably not getting to the point where they need a reintervention.
Excellent. So I would like to thank this opportunity from Professor Jamal Hoballah, and I know that he is on call this weekend, and I've took most of the question here, and I think it's a great idea to have the author with one of our staff presenting a paper. Presence of an author really puts a lot of power in discussion, and we really get a lot of benefit, and this is a brilliant idea, Professor Hoballah. The mic is yours, Professor Hoballah.
Well, thank you very much for leading the discussion. Everything was covered in a very valuable and clear manner. Just some technical questions for the audience. When you place these endografts, do you prefer to do them with a cut down? Do you prefer to do them with a percutaneous close? All percutaneous, very good. And what is your typical follow-up pattern for the endografts? I mean, we know that the vein is typically the 1 month, 3 months, the first year, etc. How about the endograft? What is your typical surveillance on these patients?
I do similar. A fair amount of those have concomitant peripheral arterial disease. So I worry about restenosis and neointimal hyperplasia. So I typically get 1, 3, and 6 months. And if at 6 months it looks really good and there's no evidence of elevated velocity, I just do yearly after. And I instruct the patients clearly to, if they develop any symptoms, to just come back sooner. There was also a question about sizing. I typically go one size to the size of the vessel. So if the vessel is 8 millimeter, I put it 10. If it's 6 millimeter, I put in, I'm 7, 8. So probably, 10 to 20% oversize.
I don't have any other questions. I think it was very nicely covered by Dr. Omar, and I think the audience sent a lot of interesting questions. Let me see if there's any other pending things. Yes, so there's a good question. How about, when you're dealing with popliteal aneurysms, not all of them end up being a localized aneurysm. Very often you may find patients who have like an arteriomegaly, and the first part of the superficial femoral artery from its origin is already 1.2 centimeters, but it's not aneurysmal. And then as you come close to the adductor canal or below, that's when you have a bigger aneurysm. And when you're dealing an open repair, you can just take care of that and accept a little bit of arteriomegaly and still do your bypass and follow the patients. Do you have any special preference based on the anatomy, based on the tortuosity, based on calcifications that will
Recording stopped.
That's okay. That will affect your decision making in the selection of the procedure?
No, I mean, I think, those patients are going to be followed for life typically. So, we can follow them depending on their comorbidities. Of course, if they have
Recording in progress.
aneurysm that are large, then we will have to, we would address them at the same time.
How about type 2 endoleaks? Have you had a lot of type 2 endoleaks? Do you do anything to them?
No, I mean, if there's growth, we would address them, but otherwise, we would just watch them.
And if you're doing open repair, do you typically do just the exclusion and ligation? And do you open the aneurysm after you've done the bypass and exclusion and clean the aneurysm from its content and suture any lumbars to prevent any growth of the ligated sac? I'd be interested in your technical comments on that.
Hopefully, there are no lumbars in that area.
I mean, not lumbars.
Geniculus. No, I don't. I'm not that aggressive. I think doing that adds significant morbidity. You really have to fillet the leg open to be able to do that. So I think I'd just do the bypass and ligate.
Yeah, I think in our experience, what we have been doing is if the aneurysm is big and compressing the vein, we tend to open it, and it just we rarely had to do more to the gastrocs attachment or anything. I mean, with a little bit of traction and pressure from below and above, you can open that sac and ligate the tributaries from within and eliminate the risk of having future growth and compression. But I think you have to individualize it. That has been a little bit our practice here at AUB, but I mean, I think totally respect your approach as well. Any other comments? Any other questions?
There is a question from Professor Samer Qusayr. He has joined us, but maybe not from the beginning. And the question of Professor Samer Qusayr: are there any factors in the patient anatomy, such as vessel tortuosity, calcification, that might affect the success of endovascular repair? Sure, all this element will affect the patency. I'm not sure, Professor Sha'ar, what do you feel about this question?
Thank you. I think, we discussed, I think, single vessel runoff probably, and is the big, restriction for endovascular or having very diseased tibials.
Yeah.
Where you just have to, bypass to closer to the ankle with the saphenous vein.
Yeah.
And I think mostly patient comorbidities really drive it, I think, more than the anatomy.
Yeah.
And I think patient comorbidities are probably the dominant factor to go endovascular or open.
Yeah, excellent. I think we covered most of the question, Professor Hoballah. The mic is back yours.
Well, I know that Professor Sha'ar has family over from overseas and everywhere, and he also generously took away time from his family to be with us today. We are delighted that he was able to share with us his experience and serve as a panelist and comment on the paper. Professor Sha'ar, thank you very much for being with us.
Thank you very much, Jamal. I'm gonna leave. I appreciate everyone, and really congratulations on this engagement. I've been on a lot of panels and a lot of meetings. The engagement is really the energy is high, and I congratulate all of you. Keep it up, and happy to be involved, and hopefully we'll be able to join the meeting at some point. Take care.
Thank you. Take care. So back to our PAVSS audience. We are delighted that you were able to be with us today. We are very appreciative. We promise you to do our best that these meetings will be valuable and will be educational. We are planning to have this year at least 2 to 3 journal clubs and 2 webinars, and we will planning to have the annual meeting in Amman, Jordan in December. So our next event is going to be a webinar on the last Saturday of February, and the speaker is going to be Dr. Carlos Bishara, talking about physician-modified endografts, how to do it, and tricks and tips and tricks. And so keep that on your calendar. We're delighted, thankful to Ultimate Medical with Dr. Mohammed Sharbini for great organization, and he will be in contact with all of you about the upcoming webinar. Also, I want to thank the audience for very engaging discussions and comments. It is these comments that make the session valuable, really. It's the presenters, each one took no longer than 15 minutes to present in a very clear and succinct manner, allowing us to have a good half an hour of discussion. So I am most pleased that on a Saturday night, even instead of being somewhere else having dinner, I am here in this session. It was a most enjoyable time, very well spent. So have a great rest of the evening, everyone. Thank you, and see you in 4 weeks. Thank you, my dear friend Omar, for your co-moderation. And again, good job, great job to Dr. Ramadan and Dr. Nabhani as our presenters.
Thank you very much.
مع السلامة.